Hello, future doctors. I'm Dakinis, and first of all, I would like to apologize because I realized later last week when I was preparing and studying for my lecture last Thursday that I made a bit of a switcheroo. I thought that this topic was for another class, and so what I lectured last week was for actually my Thursday and Friday classes. So I am so sorry for being confused. It was my fault. And so to make up for it, I am recording this lecture for all of us to learn the axial spine today. Let's start. The vertebral column is made up of 33 vertebrae, 7 of which are cervical, 12 thoracic, 5 lumbar, 5 fused sacral, and 4 fused coccygeal. Plain radiographs are still the most commonly performed modality for imaging the vertebral column, especially in trauma. And this is because, number one, it's easy to do, it's readily available. And number two, because it shows good bone detail. So, of course, the other modality that we can request for is computed tomography to provide cross sectional images of the bone and some of the soft tissues. But the primary imaging for the vertebral column is still MRI. This is because it displays excellent anatomical and pathological information, not just for the bone. Well, if you remember, um, bones are dark, or the calcified portions of the bone are low in signal, right? But because of tissue discrimination superior to CT scan, it is the only method that can show intrinsic abnormalities of the spinal cord substance, and the abnormalities in the bones may appear uh, as increase in signal in a background of calcified bone, which is low in signal. There are four curvatures seen on a sagittal plane or lateral view. The cervical and lumbar curvatures are convex anteriorly or are lordotic. So these are the secondary curves, while the thoracic and sacrococcygeal are concave anteriorly or kyphotic, which is the primary curve. Remember that in fetal development, from the term itself, we are in fetal position, which means that we are all parang curved to a ball, right? So that means the primary curve is the one in fetal position, which is this one and this one. So kyphosis, seen in thoracic and sacral or sacrococcygeal vertebrae, are the primary curvatures, while the secondary curvatures that is against the fetal position are the secondary curves. And again, these are the cervical and lumbar. The components of a vertebra are the body, pedicles, laminae, and the transverse articular and spinous processes. The neural arc surrounds the spinal canal and consists on each side of a pedicle laterally and lamina posteriorly. The intervertebral disc is a cartilaginous cushion between the adjacent vertebral bodies. It consists of a central nucleus pulposus surrounded by an annulus fibrosus. The vertebral canal transmits the spinal cord, while the intervertebral canals transmit the segmental spinal nerves between the adjacent pedicles. These are the C1 and C2 vertebrae. As you can see, they are not the conventional looking cervical uh, vertebrae because as you can see, C1 does not have a body and has this big foramen, while C2 has this dense or odontoid process. These are x-rays of the cervical spine. This is AP and lateral. We usually get more information in the lateral view. So we figure out the levels by, of course, the first one does not have a body, and then the dens inserts within it. So we know that this is the dens. So this is C2, C3, C4, C5, C6, and C7. So these are the vertebral bodies. With between them are the intervertebral disc, and in uh, X-rays we identify them as intervertebral disc spaces because we can't really see the cartilaginous cushion in between them in X-ray. What we see more of are the bones. So these are the spinous processes, and for C7, the spinous process is called vertebral prominence. For the frontal view, since C1 starts with the first rib, so above it is C7, then C6, then C6, C5, C4, and then other vertebrae are obscured. So here we can identify the spinous processes at the midline and um, the pedicles that appear to be the eyes of an owl. So this part of an AP radiograph appears as an owl with eyes, with the pedicles as the eyes and the spinous process as the beak. An open mouth view can be requested to see the dens and its relationship to C1. This shows the CT scan of the cervical spine. So can you identify which level this is? Any idea? So this is C1. As you can see, the dens uh, is seen within the foramen. And this is C2 with the dens. So this C3, C4, C5. Here, as you can see, it is the biggest because of the dens again. So this is C2, C3, C4, C5, C6, and C7. So in MRI, the surrounding calcified cortex is dark or low in signal, while the marrow, which contains fat, is bright. The intervertebral discs are a bit bright because of the fluid content or the normal fluid content within them. So if they appear dark, then that means that there is desiccation or drying up of the intervertebral discs, making the cushion between the vertebral bodies less efficient. The 12 thoracic vertebrae are distinguished by articulations for the ribs. The ribs are attached at two places. The head of the rib attaches to the vertebrae at the disc, and the tubercle of the ribs attaches to the transverse process of the cos- costotransverse joint. So these are the conventional radiographs for the thoracic spine, lateral, and AP or anteroposterior. This is what a typical thoracic vertebra looks like with the body, vertebral foramen, the transverse processes, and the spinous process. The pedicles, and this is what it looks like in lateral view. This is the vertebral body. And in frontal view, we see the owl. In the frontal view, we again identify the pedicles and the spinous processes. So this again looks like an owl. For CT scan, these are the vertebral bodies and the spinous processes. While here we see the attachment of the ribs. For CT scan, reconstruction can show us more detail for the bones of the vertebrae, but not much detail on the soft tissues, such as the spinal cord and the spinal nerves, and the intervertebral discs, unlike in MRI where we can identify if there is desiccation. So in MRI, again, this is a close-up look at the axial plane through the axial plane of a thoracic vertebra. And these are the thoracic vertebrae in sagittal view. There are five lumbar vertebrae, the third being the largest. Oblique radiographic views provide better visualization of the neural foraminae and pars interarticularis than the conventional views, which are AP and lateral. So again, these are the parts of a lumbar vertebra. And in X-ray, this is how they look like. So T12 is identified by the rib that attaches to it. So if there is no rib that attaches to it, then that means that is L1. Also, L5 is commonly above the sacral promontory unless there is a normal variant. Compare what the superior articular process, the pedicle, and the intervertebral canals look like in a lateral view to the oblique view. So this is how the oblique view appears. To just show you the parts, it's being compared usually to this Scottish Terrier. This is actually called the Scotty dog of uh, lumbar radiographs, with its nose being the transverse process, its ear, the superior articular process, its eye, the pedicle, its neck, the pars interarticularis, its tail, the contralateral superior articular process. The body is the lamina. The front leg is the inferior articular process, while the rear leg is the contralateral inferior articular process. So let's look at it again. So here again is the Scotty duck of an oblique lumbar radiograph. The eye again is the pedicle. The ear and not well visualized is the tail, are the superior articular processes. The neck is the pars interarticularis, which we scrutinize to see if there is a fracture because that it's a site where fracture can occur. And then the feet are the inferior articular processes. Again, in AP, these are the pedicles and spinous processes. While in lateral view, this is the pedicle, it's the vertebral body. This is a reconstructed image of the lumbar spine in CT scan. So for the sacrum, this is a zoomed in image of the sacrum in AP, and then this is in lateral view. For fractures, so the Jefferson fracture is, as you can see, a fracture of C1. So here, this mechanism of injury is blow to the top of the head, causing the lateral masses of C1 to slide apart, splitting the bony ring of C1, seen here. The lateral masses of C1 thus extend beyond the margins of the C2 body in imaging. So this is the denser odontoid, and these are the lateral masses of C1 in a frontal radiograph. So if there is an increased distance of the lateral mass of C1 from the denser odontoid process, then there may be an abnormal fracture or there may be Jefferson's fracture that causes it because, again, of the split in the bony ring. So this is, again, open mouth view showing the dents. These are the lateral masses of C1. In Jefferson's fracture, there can be an increase in space between the dens or odontoid process and the lateral masses of C1, as well as having lateral masses extend beyond the borders of C2. So, of course, CT scan better shows the fracture. So, in CT scan axial view, we can see the fractures that cause the bony ring to split. So, looking at this open mouth view, you can see that the lateral masses of C1 extends beyond the border of C2. Again, that is your clue to tell us that there is Jefferson's fracture. Although, of course, with that is the increased space between the odontoid process and, again, the lateral masses. Again, this shows the fracture. Normally, C1 bony ring is supposed to be intact. Hangman's fracture is secondary to hyperextension and distraction. So this is an unstable and serious fracture of the posterior elements of C2 with displacement of the C2 vertebral body anterior to C3 as illustrated here. So again, there is a fracture of the bony element with displacement of C2 anterior to C3. So here, C2 is supposed to be aligned with C3 and the rest of the cervical vertebrae, but here there is anterior displacement with a fracture. So here the fracture is not that well delineated, but there is a lucency here, suspicious for the fracture for the posterior element. Now, of course, CT scan better illustrates again the bony fracture. So we see the fracture here in eggshell and in sagittal views. This is another example better showing the fracture. So here we see the fracture. It's comminuted. And then there is a mild displacement of C2 in relation to C3. Again, there is this fracture in the posterior elements and anterior displacement of C2 in relation to C3. Clay shoveler's fracture is fracture of C6 or C7 spinous process, as seen here. Okay, this is pretty obvious. There is detachment and displacement of this bony fragment. And here in CT scan, it's also very obvious. That again is clay shoveler's fracture. Here's another CT scan showing clay shoveler's fracture. Let us now look at fractures in the thoracic spine. Scoliosis refers to the abnormal curving of the thoracic and lumbar spine. And so dextroscoliosis refers to abnormal curving towards the right in a frontal radiograph, while levo refers to towards the left. So grading of scoliosis is seen here. 10 to 20 degrees indicates mild scoliosis, 20 to 24 is moderate, and more than 40 degrees is severe. So that is in Cobb's angle, by the way. So this shows first upper to mid dextroscoliosis, in which the angulation is towards the right side of the patient. Here is dextroscoliosis, or curving towards the right. More dextro and levoscoliosis seen here. This again is probably just dextroscoliosis with compensatory levoscoliosis. And again, this is another one. So this is how a severe scoliosis looks like. This is likely more than 40 degrees in Cobb's angle. So this is severe thoracic levoscoliosis. This is lumbar dextroscoliosis. This is a schematic diagram showing the deformity. There is anterior wedging. When we say wedging, this is a wedge, right? So instead of being a box, it becomes wedge shaped. Anterior wedging, we say anterior wedging when the shortening happens anteriorly than posteriorly. So this is a wedge compression fracture. Burst fracture is a fracture involving the anterior and posterior parts of the vertebral body with extension into the posterior elements. So this is a burst fracture. These are the normal vertebrae, and as you can see, there is wedging with displacement of this vertebra in comparison to the other vertebrae. So it is posteriorly dislocated. So again, burst fracture is a fracture involving the anterior and posterior parts of the vertebral body with extension into the posterior elements. This is another burst fracture. In CT scan, we can better delineate all the fragments of the burst fracture, and in Axial, we can even see the fracture lines dissecting the vertebral body. Chance fracture is a common seatbelt injury. So the mechanism of injury is hyperflexion with distraction. Uh, the anterior, middle, and posterior columns are involved. And this is an unstable injury perpendicular to the spinal axis. So here we see a bit of wedging and uh, fracture line here. Also here. So these are fragments of a comminuted fracture involving the anterior, middle, and posterior columns of the vertebra. Spondylolysis refers to a break in the pars interarticularis, which can be hard to see, but uh, the oblique view for the lumbar spine helps for us to identify a fracture in that area. So if there is a fracture in the neck of Scotty dog, then that is spondylolysis. So here again, there is a break in the neck, and that is the fracture in the pars interarticularis. Spondylolisthesis is actually a general term for slippage of the vertebral body, but uh, for our institution, we usually use this term to denote anterior slippage in relation to the inferior vertebra, while retrolisthesis is a more specific term because retro means posterior, so there is posterior slippage of vertebra over the lower vertebra. So here, com- this vertebra compared to this one is anterior. So this is anterior spondylolisthesis. While here, this vertebra is relatively posterior, comparing it to the posterior margin and anterior margin of the lower vertebra. This vertebra is posteriorly displaced. So that is retrolisthesis. The problem with that is there may be compression of the nerve. Again, anterior spondylolisthesis is this one. There is anterior slippage of um, L5 over S1, while in retrolisthesis, there is posterior slippage of this one. For this example, it's L5 over S1. Thoracic cage is also one of the views that we request for to be able to assess the ribs well. So this is the frontal view and this is the oblique view. We ask for the oblique view, especially if we are suspicious for fracture in the lateral ribs. And that is because sometimes it's hard to see fractures that are here in the lateral portion. So in the oblique view, we can see the entire rib better. And for this, what abnormality can you identify? Can you see an abnormality? 2, 3, 4, 5, 6, 7, 8. I think in the eighth rib, we see discontinuity, so that is probably a fracture. What else? Did you notice that this is the only portion of the lung and the entire thing is, or the entire lucency is devoid of lung markings? So we know that this is abnormal air collection. And then here we see that there is um, obliteration of the costophrenic angle. So then there is this sort of meniscus. So this is probably pneumohydrothorax with a rib fracture. Comparing a chest X-ray to a TKH, uh, there is emphasis on the bones in TKH. I think that's it. Thank you for your kind attention. And again, I'm sorry for my confusion last week. I hope that you do well in the exam. Bye.